First, I want to thank Dr. King for being kind enough to give us our season finale of our hit series, Grand Rounds. We'll be starting up again, I think, second week in August, but you'll be getting an email about that. So if you order your tickets now, we have a special rate for the season seats. Thank you.
Well, today we're going to talk about the hemorrhagic fevers as a group, but I'm going to spend a good deal of the session on Ebola, since that's sort of become the penultimate and best understood of all the hemorrhagic fevers. The reason for that is between December 2013 and today, there's been a progressive and very broad outbreak of Ebola disease in several of the West African countries. And we'll talk, of course, more about that. What I do want to do at first is give you an overview of the hemorrhagic fevers. Then I want to characterize Ebola disease. And you'll see that I've called this Ebola disease, not Ebola hemorrhagic fever. And that's because most patients who get Ebola don't get massive hemorrhage. They don't die of hemorrhage. They die of shock from hypovolemia, from nausea, vomiting, and diarrhea. There certainly are those patients who have massive hemorrhage, and most patients will have some hemorrhage. We'll talk about the sources of Ebola, and this will include animal carriers, animals and people that are infected, and animals and people that are diseased. Now, like many diseases historically, and histoplasmosis is an excellent one, we identified the disease because of seeing patients who had lethal disease. And it took quite a while to realize that the vast majority of people who have that, who have histo, just like Ebola, never have any identifiable disease. So when they went back and started looking at populations in Africa looking for antibodies to Ebola, lo and behold, they found them in many patients who'd never had anything that looked like clinical Ebola. So we'll talk about monkeys, pigs, bats, and people. We'll talk about human-to-human transmission and what that means to us. We saw what happened in Presbyterian Hospital. That's routine, classic occurrence in Ebola disease because people think you can take care of it in a fairly direct, simple way. Then we'll review the history of Ebola outbreaks. And if you don't get anything else out of this, I want you to understand that the hemorrhagic fevers don't really come and go. They're there. They're endemic. Ebola is endemic throughout Central Africa, east and west. The reason we see outbreaks is that's what catches our attention. The news media starts talking about thousands of people dying, and we get all interested. And then groups like the World Health Organization decide what they need to do is collect money from countries because they're going to have 2 to 3 million cases. Well, that didn't happen, but it's a fairly classical bureaucratic response to a problem that is potentially worldwide, but for the most part local, and its history is local. And then we'll talk a good deal about the therapy for Ebola, because this went from IV fluids in November of 2013 to over 30 drugs plus vaccines that are present a year and a half later. That area has just exploded. All of a sudden people realize that There are ways to combat this disease with both old and new drugs. Well, a couple of things about the hemorrhagic fevers, and that is that they're, for the most part, all caused by one of 12 enveloped RNA viruses, and they're only in 4 families. The Arinaviridae, Buniviridae, the Filoviridae, and the Flaviviridae. The Filoviridae is the family that has Ebola and Marburg. Of those, Marburg was really the first one to make itself known, and it's named after Marburg, Germany, where the first outbreak in Europe occurred. Well, let's look at the arenaviruses, and they're old world and new world arenaviruses that cause hemorrhagic fever. And of interest, that Lassa fever virus, which was really the first of this new group of hemorrhagic fevers that were recognized a couple of decades ago, is the one that's different. It's slower in onset and has a very different outcome depending on several things with regard to the patient. If the patient's pregnant, they're going to die. And a lot of the first patients that went in with Lassa were pregnant. This was the first time we saw what's now classic for all of hemorrhagic fevers, which is magnification of the disease when somebody goes into a hospital. And that's because of, in that case, contaminated things that were not supposed to be reusable but were reused. Needles, Sharps instruments, and spread the disease rapidly. The New World arenaviruses, and I'll show you this in just a minute, are widely expressed through South America, and have had a very limiting effect, particularly in Brazil, on how the Brazilian government can spread out into the western part of their country. They keep sending in exploratory groups, and they don't come back out when they're found that many of them have developed a hemorrhagic fever. The bunniviruses, everybody's heard of Rift Valley fever and Crimean Congo, and of course hantaviruses. The filoviruses, Ebola and Marburg. The flaviviruses, things we don't think about very often. We think the hemorrhagic fevers are kind of new diseases. Yellow fever has been with us for a long time, and so has dengue. Now, if you look at the literature, be careful about dengue because, and don't confuse it with chikungunya virus, because about 100 years ago, what we would call chikungunya virus was designated as dengue. And they're two very different viruses. And then, of course, there's tick-borne fever, which we don't have a particular problem in the U.S. with. Now, this is an example of how much we really have, how many countries are involved, essentially all of them, in South America, with the exception perhaps of Argentina, and a few bordering the Atlantic. But these are virulent, they are aggressive diseases, and up till now there's been no sense of therapy for these. People get sick and they either live or they die with them. Not much attempt at therapy in those areas that are infected. Now, as a group, the hemorrhagic fevers, the agents of hemorrhagic fever, are all lipid enveloped. They're all single-stranded RNA viruses. I'd point out the arenaviruses have two strands of RNA, a short one, a long one, but both of those are single-stranded. They have similar syndromes, but the pathogenesis differs. They persist in nature, and fortunately for us, they're vector dependent. And because they're vector dependent, and those vectors don't move around a lot, they tend to stay in one place. Now, this is not always. This is not always true with mosquitoes, but for most other animals it is. Bats are a particular problem, and we'll talk more about that in a second. Again, they're geographically restricted by their host, and this is an important point, and that is, if you're going to work with Ebola, you're going to have to be, in this country, in a level 4 biocontainment facility. And yet we were told that, if somebody comes in with Ebola, we can just put them in a regular hospital as long as they have a private bed, and just use some regular, coverings and a mask and some eyeglasses, and that ought to do it. And of course that was not true. And we learned a hard lesson that way, but exactly what you'd expect occurred, and that is someone with Ebola comes in. In that case, they were identified reasonably early, once they got to the hospital, that they had a hemorrhagic fever, and yet they still infected 2 people. 2 people who were trying very hard not to get infected. Now, with the exception of loss of fever, the group tends to have a very abrupt presentation. They'll have fever. It's often biphasic. It'll go away for a day, maybe 36 hours, and then it comes back. Myalgias and abdominal pain are very common, but it's the nausea, vomiting, and diarrhea that lead to death of most of these people. They have nausea and vomiting so they can't take in fluid effectively, and they have diarrhea so that they lose fluid, and a lot of it. This leads to hypovolemic shock and death. In many of these patients with any of the hemorrhagic fevers, they will get small vessel involvement, and they get increased permeability. We'll go into why that is in a little bit. And they may or may not get a true vasculitis. There are multi-systems that are involved, and basically, given time, all of the organs in the body are going to be damaged. But early, it's liver and kidney that take the brunt of the infection. As we said, the hemorrhage may be of small volume, and more often is small volume, but there is a thrombocytopenia that occurs, and it's due to clumping of platelets along the small vessel walls. There's a very poor prognosis with these findings, as you might expect. By the time the patients get full-blown renal failure or extensive hepatic disease, they're not going to respond well to any therapy. So if you're going to intervene effectively, you've got to do it early. And when the lesson was learned about giving IV fluids, all of a sudden the mortality in certain areas fell before we ever got any drugs or vaccines. Now, this is a schematic of what happens with exposure to the filoviruses, either Ebola or Marburg. They attach to either dendritic or cells or macrophages and invade. Those cells are then widely distributed throughout the body, primarily involving lymphoid tissue early on, where they're magnified and then disseminate. There is a release of cytokines and chemokines that leads to inflammation that follows by leaky blood vessels, and it continues from there. What you see here is a depiction of the platelets adhering to the vessel walls, and once this is initiated, it's very difficult to reverse this. Adaptive immunity is extremely important in Ebola and Marburg. And this is really interesting to me, and I hope to you, that the setting of whether somebody's going to live or die depends on how they produce antibodies and what happens with their lymphocytic cells. There's early on lymphopenia, early on antibody production is shut down. If a patient does not develop effective antibody and lymphocyte mediated immunity by day 3, 72 hours into the clinical, not the initial, but the clinical period, they are probably going to die. A very high mortality rate in those patients. So the survivors already have antibody by day 3. Now, this is the original electron micrograph from CDC. And they looked at this and immediately recognized it as a virus, but certainly a very strange looking virus with this big knot in the middle of it, and just something they had never seen before. The genome of Ebola is negative stranded, as we've said, and it has 7 structural and regulatory genes. And I'll talk about some of these. The glycoprotein is particularly important, and really leads to attachment and being able to invade dendritic cells. Very important structure. Now, this is a depiction of the protein structure of Ebola, and this would be that knot that you saw, a lot of proteins, and then the tail, and this is the area in which the proteins for a new virus will be synthesized. And this is another depiction from the Swiss Institute of Bioinformatics. And it shows up here, these little clubs that are the glycoprotein. And then over here, the genomic RNA that's forming. There are a host of other proteins. All of them are important, but the glycoprotein seems to be especially important in binding to cells that are to be invaded. Now, this just comes from Science of February the 27th of this year, and is a depiction of Ebola up here. And as it enters by macropinocytosis, first it has to bind to a carbohydrate binding protein, then it's picked up and involved in an endosome, at which point cellular proteases, these are the animal's proteases, will cleave the glycoproteins. If you see these little bulbs up here, you see them all there, and here you start seeing they look like sticks. That's an example of the glycoproteins being removed. Niemann-Pick protein, which everyone along their medical school career wrote about Niemann-Pick's disease. This protein is involved in the ability of the virus to fuse and thus reproduce itself. But for that to happen, it uses these 2-pore calcium channels, and it's got to get rid of a lot of calcium that's within the endosome and eventually, which becomes a lysosome. After fusion occurs, then genome release and viral replication. Now I'm going to talk a little bit about the actual viruses of Ebola. And again, I want you to think about the history of these and the timing, which this slide doesn't show the timing, but we'll get into that. Different viruses had distinctively different mortality rates. Zaire had up to an 89% mortality rate. And Sudan, which occurred simultaneously with the Zairean outbreak in 1976, had a much lower outbreak. The reason for that is never really been clear. A few years later, the Reston virus, that's from Reston, Virginia, 40 miles outside of the capital of the United States, there was a new Ebola that was identified. This Ebola was brought in monkeys. The monkeys were housed at a housing facility before they were released for research. During this process, all of a sudden, all of the monkeys started dying of massive hemorrhage. And CDC and USAMRAD were identified as the right people to call, and they came out and cordoned off the building, scared two of the men that were working in there to death. One of them literally walked out in the front yard, fell over, and had a heart attack. So the people that were there thought, oh my God, this hemorrhagic fever is instantly killing people. Well, they scared him into a heart attack. He was fine. The important part of that is those guys all got infected, but none of them got disease. And it was a very important lesson for Ebola virus. It appears in that outbreak, the monkeys, which were housed in different rooms, were spreading it by the air. It was airborne. And it's possible, though we don't know that the humans got it the same way. But they were handling the animals, so you can't really be sure. There was a virus named Cote d'Ivoire. Name has been changed to Thai forest. And don't know the mortality rate. There was only one case, and he lived. And then Bundibugyo, which came out of Uganda. And I'll show you a picture just to refresh your memory about where these countries are. Zaire, by the way, is the name. In '76, the country was called Zaire. It's now called the Democratic Republic of Congo. So those are the same places. Marburg, different virus. There's only one strain as opposed to multiple, and has a lower mortality rate. Now, this is the area that we're really concerned with right now. And in this area of Guinea, Sierra Leone, Liberia, you see the darker the area, the more cases there is. So it's not uniform in its density of cases, but it's fairly dense within the darker areas, particularly in Sierra Leone. Now, we thought this outbreak had finally settled down. And then 2 weeks ago, all of a sudden it was reported it was cranking back up in Liberia and Sierra Leone. So there are now more cases that are occurring. Now, why are they doing this? You know, why is the virus coming back? Well, it never left. We don't know when it started. Our first knowledge of it was in '76, but it's been in the background in the animal vectors for all this time, even though it may not go reported in the news media except every 10 or so years. So there's a long range between the time evident disease occurs. The time frame of the disease is after infection, a few days into this, 2 to 21, it said, that's what it said. My daughter got involved, she's at CDC as a statistician, and was asked to be one of the people that went to the airports and identified patients and tracked them down. She said they could identify no one that had gone more than 16 days in the African sources as well as the sources in Europe and the United States. But the point is that 21 days, if you pass that, you're probably going to be safe. Now there are some groups that want to double that and go to 42 days, but it appears sometime between 16 and 21 days is the period of transmission, of acquisition of disease. First things that happens early on are high fever and generalized pain, headaches, myalgias. Diarrhea can begin then. As time goes on, chest pain, shock, and then death. Late symptoms in patients who don't die right away are kind of interesting, and that they include hiccups. And these people who start off with hiccups tend to do poorly. Vomiting blood and bloody diarrhea are obviously severe consequences of the disease. And also blindness can occur. Now this can occur in people who survive, so they can be blind. And what is the transmission period? You know, we're saying 2 to 21 days. If the patient lasts that long, they shouldn't get clinical disease. But on the other hand, how about people who've had Ebola? How long can they transmit it? And it's now been documented through sexual transmission up to 9 months. So once tissues get involved, it may be quite a while before they're truly cleared. Well, what are the prognostic features that we can actually identify? And there aren't very many as to who lives and who dies. And part of that is because the mortality rates are high. How many people in here are younger than 21? The gentleman in the back with the glasses, right. So none of this applies to anybody in the room. That is, all of us are older than 21. That had a 57% mortality. If you're over 45, and I won't ask, that's a 94% mortality. If diarrhea is present during the disease, particularly early on, there's a 94% mortality. If diarrhea never really occurs, the mortality drops to about 65%. So as you can see here, there's not a lot of identifying features where you can put people in a box and say you're going to live, you're going to die. Again, the mortality is so high for everybody, it's hard to identify things that would clearly separate them. Now, again, this is an electron micrograph of Ebola. And after the incubation period and the onset of disease, if there is generalized bleeding, there is a high rate, 53 to 89% case mortality. This virus lives in animals that are in the African rainforest. The reservoir, one reservoir, is considered to be bats, in particular the fruit bat. There are other reservoirs, clearly. And I'll talk just for a moment about bats because they're interesting creatures. There's person-to-person transmission, as everybody knows, animal to person, This is in particular where natives will eat bushmeat, which are dead animals, sort of like our roadkill. They will take that to supplement their protein intake and can transmit the disease that way. Now, a fairly new observation, just recently published, is that blood and body fluids can transmit disease up to 7 days, even if they're dry. So if somebody comes and touches a surface and they have Ebola on their hands, that Ebola will remain on the surface in an infectious state for up to 7 days. And that may play a big role in how the disease is so effectively transmitted. Now, here's our little furry friend, the fruit bat, and this is considered to be one of the main vectors of Ebola. Now, there's some interesting things about bats, and Science had a really nice article going into the genetics and the diseases of bats. Bats carry rabies. They carry rabies. They don't get sick with rabies. They pass it on transovarially and give it to other animals, including us. They do the same thing with Marburg virus and Ebola. They don't get sick with these things. And there's a lot of investigation going on as to why that is. Is it body temperature? Is it something else? Is it their innate immune system? But these are little carriers of significant disease of several viruses. All right, I'm going to briefly talk about the history of Ebola. And this is what I'd like y'all to sort of hone in on. A couple of things that continue to this day, every time you see an Ebola outbreak. In Zaire, there were multiple family members of a single family that got sick enough to come into a hospital. Once that happened, there was magnification within the hospital. And a lot of that was reuse of contaminated equipment. We don't do that over here, but we still have the same outcome of new cases occurring within the healthcare setting. In that outbreak, there were 318 infections, 280 deaths, 88% mortality. The fascinating thing was this is the first outbreak that was recognized. They didn't recognize it as an outbreak for 3 months. People just kept coming in and dying and dying and dying, and nobody was able to put it together as a single agent. Simultaneously in Sudan, right across the border, another virus is occurring, doing the same thing. Shows up in a family, they get sick, they go to the hospital. The disease gets magnified in the hospital, spreads through the community. We've already talked about Reston. That was in '89. Now look at the difference. We're talking about 1976, and when we jump to 1989 before we realize this stuff is still around. After '76, the idea was maybe this has gone away. So Reston shows up. It's a new Ebola strain of pigs and also infects monkeys. It comes from the Philippines instead of Africa. Monkeys died from this infection. Humans got infected but didn't get disease. So they neither got disease nor did they die. During this, respiratory transmission was thought to most likely be caused or cause part of the outbreak within the animals because of the separate facilities and the only thing connecting them were the airways, and may or may not have involved the humans. Again, the Ivory Coast was a single person, but it was a new virus. That's kind of interesting. One person shows up with a new Ebola. Then we jump to the following year, 1995, and we're right back to Zaire with another major outbreak. 81% mortality. Sorry, I keep hitting that. Uganda, about 10 or 12 years later, shows up with yet a new strain. It differs in that it really does have a lower mortality, apparently. But at that time, the appreciation of using IV fluids and caring for these patients and isolating them from other patients and reducing their diarrhea and keeping up with their volume status may have had more to do with a 25% mortality rate than a new strain. But nonetheless, lower mortality rate, and it was a new strain. Okay, well, here's Zaire, now the Democratic Republic of the Congo, Sudan. This first 1976 outbreak occurred here. Uganda shares the border. So this is all together in one area and goes from East Africa to West Africa through the central part of the continent. Now we have this area involved with Liberia, Sierra Leone, Guinea, and we keep thinking this is going away, and it keeps coming back. Now, how many cases are we really talking about? This is of the 22nd of this month. Total cases 27,051. Laboratory confirmed almost 15,000. And deaths attributed to Ebola 11,140. All in this area, which is fairly small. All contiguous, and what was happening is in certain areas of these countries, the borders are open. In certain areas of the countries, individuals who were sick had families in another country. When they got sick, they knew that if they were found, they would be picked up, brought to a hospital, and they knew what the outcome of that was. So they frequently migrated to find other family members, either in their country or outside of their country. And it's thought that this fear of what was going to happen to them drove the spread of this virus. And so at one point, government forces literally encircled a little town. I mean, sounds like a grade 3 TV movie. But they encircled a town and were going to prevent people from leaving that town because there were a number of Ebola cases. And this was going to be, they were trying to cohort infected patients. Well, people found out about this and just fled. Well, where did they flee to? They fled across the border into other parts of their own country to family members that were spread out, and with them brought disease. So it's very difficult to know what the best way to handle this on an epidemiologic scale when you're dealing with a population in particular that doesn't really trust the government. Now, pathogenic mechanisms of Ebola, we've talked about contact with any tissue or fluid as old as 7 days, even if it's dry. The infected monocytes and dendritic cells are sort of the starting point. And then there's a destruction of the endothelial barrier as the virus continues through mechanisms of TNF and growth-regulated protein. And this can be an event that occurs rapidly within a few days from onset. Well, what are the mechanisms that lead to survival? Well, the most important one is antibody production to nucleoprotein VP40 and also glycoprotein. If antibodies develop rapidly to those, the patient has a good chance of surviving. Doesn't guarantee their survival, but they have a good chance of survival. Much better than if they don't get those. And viral clearance is associated with cytotoxic lymphocytes. But remember, early in the disease, in the first 72 hours, there's lymphopenia. The virus clears the blood of lymphocytes. So that's a particular risk for those patients. Infection of cells lead to impaired T cell priming and a very poor antibody response. Induction of pro-inflammatory factors, and this can lead to hemorrhage with an inflammatory, systemic inflammatory response syndrome. Diagnostic tests, we have good ones now. The ELISA is able to be used, in particular looking at the IgM, not the IgG. This can occur early on, and then there's a real-time polymerase chain reaction that's very useful early on. And later in the course of the disease, looking for IgM and IgG. You can't just look for IgG. They found that out that many people already have IgG. They don't have any disease, never did have any apparent disease. But the combination of IgM and IgG show you that you're along in the disease process. It's not acute disease, which would only have IgM. Retrospective diagnosis can occur with immunohistochemical assays, PCR, and actual virus isolation. Now, this is a scanning electron micrograph. Before you saw transmission EM, this is a scanning electron micrograph. And that's Ebola swarming over the surface of the cell. That sort of gives you an idea of what's really going on. It's a massive number of viruses attacking a single cell. Now we'll talk about therapy, and I'll quickly point out early developments involve DNA-based plasmid vaccines. Russia led the way in this, and they had some really interesting means of getting DNA produced by injecting viral RNA directly into the nucleus of cells. And they did this by binding RNA to gold particles and using a gene gun to directly inject gold particles into cell nucleuses. Turns out this didn't work so well. One of their investigators acquired Marburg virus when he was injecting a mouse, accidentally injected his hand, and was treated with a number of their vaccines and went on and died. A vaccine based on a replication incompetent chimpanzee respiratory virus has been engineered to produce Ebola proteins. This is sort of getting into a really interesting area, because some of the vaccines now are being looked at as being able to be given by the respiratory route, which would make a lot of sense if you're dealing with a lot of people. Vaccines that are under development, there's live attenuated vaccines, and they're coming from the same family as the family that causes rabies, but they're engineered to carry critical Ebola proteins. There's one based on vaccinia virus and engineered to do the same thing. Now we get to the things that are likely to really lead us to effective treatment in humans. And these are the replication defective viruses with defective VP30. And it protects non-human primates against lethal Ebola if you vaccinate before you give Ebola. But the question is, what can you do after a person gets Ebola? Well, there's a replication incompetent vaccine. Because of the risk of Ebola, they treated it with hydrogen peroxide to inactivate it, but it still provided exposure of the immune system to all of the Ebola proteins as well as Ebola RNA. So this vaccine gave the immune system everything it needed without suppressing the immune system. Another approach was gamma-irradiated inactivated vaccine. Turns out that didn't work. The gamma rays had to be so intense to prove that it was an inactivated virus that it just didn't work. The proteins were so altered by the radiation that they didn't induce immunity. Now, for favipiravir, which is approved in Japan for influenza, has recently been identified as a drug that may come out very shortly and be useful in treating patients with Ebola. And brincidofovir, which is for DNA viruses, particularly pox viruses like smallpox, CMV, and other DNA viruses. Turns out it's also effective against some RNA viruses, one of which is Ebola. This is the most interesting drug of all, perhaps, BCX 4430. When this was given to macaques, 48 hours after they were infected with a lethal dose of Ebola, they didn't die. This all of a sudden puts it into the realm of something that's actually useful, where you don't have to try and vaccinate or try and treat somebody before they get exposed. And then there are some antisense oligonucleotides that are being developed, and these will block RNA gene expression as well. But this BCX is really looking like it or drugs like it are going to be perhaps a major breakthrough. You've probably heard of ZMapp. It's a cocktail of 3 monoclonal antibodies directed against Ebola surface glycoprotein. And it did increase survival in non-human primates. It was given to patients, but we don't know if it actually, they survived, but we don't know if it actually was the cause of their survival. Then there is another fascinating approach, which is TKM Ebola, which is a short interfering RNA. Now, there are all sorts of uses for short interfering RNA, some of which are not good for people. And it binds specific sequences of Ebola and terminates viral replication. The nice part of this is it's very specific. It only gets those parts that are associated, that genome of that virus. It can also get the genome of a chosen person. You can choose one person, get their genome, and you can give them anything you want. Okay, TKM Ebola preparation also targets 3 different Ebola genes, and it increased survival in macaques from 0 to 86%. That's pretty impressive. And this was when it was given an hour after lethal challenge. They didn't give it, at least I haven't seen any of the data where they gave it later than that, but perhaps it'll work later on, when given later on as well. Now this is my second to last slide, and I want you to look at this and remember about the families that moved around Remember about the history, this disease doesn't go away. It just sort of gets less common. Here you have a single person right here who gets Ebola. And after 3 generations now, 21 people have acquired Ebola, many of whom have died. So if you put that on a larger scale and you're looking at how quickly this can spread, you get to see the outcome. Now this is George Santayana, and he is known for his comment about, among other things, those who cannot remember the past are condemned to repeat it. And it seems like with Ebola and the hemorrhagic fevers, we're doing just that. We forget that these diseases are really there all the time. They may not be causing a major epidemic, but what constitutes a major epidemic? It's kind of what the Western media says is a major epidemic. It would be possible for certain areas, as occurred in Zaire. We went for 3 months and nobody knew what was going on. This is an approach that I hope you'll understand that Ebola has once again come on under the public eye. It's now gotten treatable, and treatable with simple things like IV fluids and decreasing diarrhea, as well as substantially different things such as drugs and vaccines. There's a lot of work being done on a vaccine that could be given to large populations and terminate the human transmission of this disease. Well, I'm going to stop here and ask if there are any comments or questions that I might answer. Okay. Well, I thank you for your attention.